Well, thank you very much. Good day. My name is John Marshall. I'm speaking to you from Toronto, Canada. I'm a professor of surgery and intensive care at the University of Toronto, and I work at St. Michael's Hospital here. And what I'm going to speak to you about today is a perspective on sepsis that suggests perhaps even more fundamentally than that we have made specific mistakes, that the framework or the hypothesis that we have proceeded in our studies is simply wrong. I want to start with my disclosures for my talk this day. There are some commercial and academic disclosures. In addition, I want to acknowledge that Toronto sits on the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and Mississauga of the Credit First Nation. So what is a hypothesis? Well, according to the Oxford Dictionary of English, a hypothesis is a supposition or proposed explanation that's made on the basis of limited evidence as a starting point for further investigation. From a scientific perspective, the importance of a hypothesis is that it frames a research question and therefore allows us to ask one or a series of questions that we can evaluate using appropriate scientific techniques. So our concepts of a disease help to frame a hypothesis. Our current concept of sepsis is laid forth in the Third International Consensus Definition Conference, the Sepsis 3 conference, that defined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. First and foremost, I think it's important to recognize this represents a significant advance over earlier definitions, but it still leaves us with some areas of uncertainty, which mean that the hypothesis itself does not lend itself nicely to research. The assumption behind this hypothesis is that a single cause, i.e. infection, evokes a common response, i.e. a dysregulated host response, and a stereotypic phenotype, organ dysfunction. And so the problem here is both the assumption of a single trigger and the assumption of a single consequence. If we take this hypothesis, the current sepsis hypothesis, we can break this down into some questions that we could approach from an experimental perspective. Some of these we can answer well, other questions we can't. So let's look at this. If sepsis is the response to infection producing organ dysfunction, then can organ dysfunction be attenuated by the rapid diagnosis and treatment of infection? And I think the answer here is an unequivocal yes. These are data from Anand Kumar showing the impact of the timely administration of antibiotics in patients with septic shock. But there certainly is a wealth of data and experience showing that early in the course of infection caused by susceptible microorganisms, the use of appropriate antibiotics can actually prevent organ dysfunction and therefore prevent or attenuate the systemic inflammatory response. The more problematic question, however, is, does correction of a dysregulated host response prevent organ dysfunction and increase the survival of patients who have infection? So the problem here is that the host response is enormously complex. It is highly variable from one individual to the next. It is conserved, and it is essential for a response to an infection. And therefore, the assumption that that response is a pathogenic process is an inadequate one. This shows simply an experimental situation where the exposure to LPS, which is mediated through toll-like receptor 4, results in differential expression of over 3,700 different genes. Now, we know that endotoxin can trigger a clinical state that looks like sepsis. We know it from this case report of a depressed lab worker who tried to end it all by injecting himself with a high dose of purified endotoxin, and he developed a picture of classical septic shock. He ultimately survived this, but his chemical and clinical profile looked very much like we imagine septic shock to look like. This, of course, is endotoxin and not infection. And so already you see a little chink in the armor of the sepsis hypothesis because this is not viable microorganisms, but endotoxin. Be that as it may, it's a microbial product, but we have shown that there are many, many different things that can be manipulated in mouse models of endotoxin challenge that have no effect when you give them to humans with sepsis. And so the concept that by targeting any one of these individual elements of this complex sepsis cascade, that you could help patients is a hypothesis that we have yet to be able to support, despite the fact that there are many plausible and effective targets in mice when they're challenged prior to the insult. I want to just develop this a little bit further because I want to emphasize the importance of that response in a healthy and adaptive response to infection. These are data from the clinical trial of Aridiran, the ACCESS trial that looked at an antagonist of the endotoxin receptor in patients with sepsis, found no effect at all on survival when the drug was given and was a, quotes, negative trial. But the trial did show, surprisingly, an increased risk of mortality in those patients who proved to have gram-positive infections and received treatment with Aridiran. In other words, the response to endotoxin actually potentially benefits those patients who have gram-positive infection. It's not a single response that can be compartmentalized and treated as a common physiologic process. This is further complicated by the fact that endotoxemia may not occur in some patients with gram-negative infection, but does occur in a number of patients who have multiple trauma. These are data looking at a cohort of patients who sustained multiple traumatic injuries and were admitted to an intensive care unit. You see that they were not endotoxemic at the time of hospitalization, but by 3 days after injury, a number of them had high circulating levels of endotoxin, and that was associated with a worse clinical outcome. So this is not infection. This is the same trigger that we study in infection, but it's arising in a population of patients whose insult was trauma. If we look at any of a number of different mediators, we see this same problem, which is heterogeneity is the fundamental property of the phenotype of patients with sepsis. So here we see studies neutralizing tumor necrosis factor in patients with sepsis. Overall, there is a slight suggestion of potential benefit, but the absolute magnitude of that effect is small. It's perhaps 2% overall, and we don't use anti-TNF agents in patients with sepsis. We do use anti-TNF agents routinely in patients with autoimmune diseases, such as rheumatoid arthritis, and we see a significant impact on clinical outcomes. So why is this the case? Well, again, the hypothesis that neutralizing TNF is going to be beneficial in all patients with infection simply is not supportable. Certainly it's not in preclinical models. These show the effects of neutralizing TNF in a broad variety of animal models of sepsis. It improves outcomes in gram-negative infections. It improves outcomes in endotoxin challenge. It has no impact in a complex infection like cecal ligation and puncture, and it actually causes harm in some gram-positive infections, such as pneumococcal infections. 21 animal studies showing harm for neutralizing TNF in pneumococcal challenge. There's also evidence of harm for neutralizing TNF if the organism is more of a secondary type of organism, such as Listeria or Candida, intercellular organisms. The host response is actually impaired and outcomes are worsened. Now, finally, the hypothesis that sepsis causes organ dysfunction through an altered response to infection ignores the fact that this altered response is characteristic of multiple non-infectious processes. I showed you data on multiple trauma, but here are some data looking at patients with ARDS and pneumonia. And what you can see is that patients with ARDS have higher serum levels of tumor necrosis factor than patients who have pneumonia. So this is not the signature of an infection. It's the signature of harm and a variable response to manipulating that signal in experimental and in human studies. So I say the sepsis hypothesis is fundamentally wrong because it implies a linear process. All infections produce a common response that results in organ dysfunction. And I think what we need to do is we need to unpack this concept to recognize that there are endotypes. In other words, that they're within a given process, such as a response to infection, there are multiple different types of response that are genetically determined, that are determined by multiple other factors, but occur within a disease or a phenotype. But equally, there are exotypes. So there are common molecular mechanisms, those that might be the endotypes, that can occur across a variety of different syndromes that may be common to sepsis, ARDS, pancreatitis, and trauma. And so that moving forward in thinking about sepsis, we have to recognize that it is both too restrictive and too generalized to inform effective treatment decisions in clinical trials. So just to conclude, our current understanding of biology, and complemented by results from clinical trials, demonstrates emphatically that the concept of sepsis is too simplistic to guide the development of effective new therapies. Thanks very much for your attention to my talk this afternoon.